Sensory system examination begins by distinguishing between primary and secondary modalities of sensation. When primary sensation is normal but secondary modalities are lost, it implies a lesion in the parietal lobe. Evaluation of the exteroceptive system involves testing the spinothalamic tract through pain and temperature assessment. To test pain, apply the sharp end of a pin with sufficient force to produce pain without penetrating the skin. Hold the shaft of the applicator stick lightly between the thumb and fingertip to ensure consistent stimulus intensity. In spinal cord disease, clinicians often observe analgesia more than anesthesia during the sensory evaluation. Assess temperature by applying test tubes between 5 to 10 degrees Celsius and 40 to 45 degrees Celsius. Note that temperatures significantly outside this range will elicit pain sensations rather than thermal appreciation. Tactile sensation is tested using a wisp of cotton or a soft brush gently applied to non-hairy skin. For patients with diabetic neuropathies, utilize specialized tools like Von Gray's hairs or Semmelweis monofilaments. Proprioception evaluation focuses on the sense of position and motion of the limbs in space. Test joint motion at the metatarsophallanggeal joint of the great toe or the distal interphalangeal joints of the fingers. Hold the relaxed digit on the sides to eliminate cues from pressure variations during passive movement. Healthy young individuals can typically detect movements as small as 1 millimeter or 2 to 3 degrees. Position sense is assessed by having the patient copy a hand position with their eyes closed. Vibration sense, or palæsthesia, is preferentially tested using a tuning fork with a frequency of 128 Hz. The timed vibration test is normal if perception lasts 10 seconds or more in the lower limb. In the upper limb, the normal duration for perceiving vibration is 20 seconds or more. Romberg's sign indicates posterior column dysfunction if the patient sways significantly upon closing their eyes. Pseudoathetosis presents as slow, writhing finger movements when the upper limbs are extended with eyes closed. Abates sign is the loss of deep pressure pain, often seen in neurosyphilis affecting the posterior column. Secondary modalities like two-point discrimination measure the distance required to recognize two simultaneous stimuli. Normal discrimination distances are 1 millimeter at the tongue tip and 2 to 4 millimeters at the fingertip. Graphesthesia is the ability to identify letters or numbers traced onto the palm while eyes are closed. Stereognosis tests the ability to identify common objects like a key or coin by touch alone. Tactile extinction involves stimulating corresponding areas on both sides of the body simultaneously. The spinothalamic tract carries pain and thermal sense via A delta and C fiber endings. Fine touch and vibratory sense travel through the fasciculi gracilis and cuneatus to the medial lemniscus. Cerebellar disorders often present with ataxia, manifesting as a reeling and wide-based gait. Dysmetria is characterized by the inability to control or limit the range of coordinated movement. Dysdiadochokinesia prevents the patient from performing rapid alternating movements like thigh padding. Scanning or staccato speech involves slow, explosive enunciation with hesitations at the start of words. Intention tremors appear as rhythmic oscillatory movements as the limb approaches a specific target. Nystagmus may be observed with the fast component maximal towards the side of the cerebellar lesion. Hypotonia is more noticeable in proximal muscles and is typically ipsilateral to the cerebellar lesion. A pendular knee jerk is considered abnormal if the leg keeps swinging more than 4 times. The finger-to-nose test requires fine coordination between the shoulder, elbow, and wrist joints. Lower limb coordination is assessed using the heel to shin test and tandem walking.